We're very privileged to have Marc Ruel here with us. We're having a little conversation. I'm going to ask him about his insights about cardiac surgery, life, and so on, and let's see where it goes. So, Marc, welcome.
Thanks for having me.
Welcome to Houston. Yeah. You brought the good weather with you.
Oh, yes. For some reason, it always happens when I come here.
It does always happen.
You come bring the good weather. I leave a snowfall, and I come here, and it's all sunny.
The week before is always bad, and the week afterwards is always bad. But when you're here, and this is true, you've been here so often that you've seen that to be so. So welcome. I can't believe it's been 13 years, and you've been coming here for 10 of those. Yeah. So
no, I appreciate that. It's kudos to you and the Methodist team, because this conference is really a wonderful educational venue. It's one that's focused towards sharing our expertise, right? And I would say, as heart surgeons, do we do that often enough? That begs the question, in my opinion. Do we sometimes think that we want to be exclusive in what we do? And certainly this conference is not about that. It's about sharing the knowledge. It's about showing each other tips and tricks that make it available. So it's very, very hands-on. And Methodists, in my view, I've been here, as you say, perhaps 10 times, is really a beacon in surgical education. And you've been a big part of that. You've, I think, correct me if I'm wrong, I think you were the founders of this conference, and the resources around it have made it really something, quite an achieved product. And I think, it's a popular conference, it's great attendance. It's something that is a kind of a go-to destination every year. So kudos for that.
Well, that's very kind of you, Marc. But really the conference is you. It's because you and others like you are here. We just provide a gathering place for it, okay? And you're the attraction. You're the reason why people come. So we're very, very grateful to you for that. Now, let me just try to unpack who you are a little bit. I think people would be interested to know. We all have our own life stories. Why did you become a heart surgeon? Why?
Yeah, that's a big question. I think heart surgery is very, very interesting. We like to think that surgery is a science, but in a way, I would argue that it's often a craft. And I think we are learning a craft. And often when I have a fellow, I say, I'm the sculptor and you're my apprentice, and you're learning to sculpt, and you will sculpt, you will take some of what I do, and you will discover some of what you want to do, and you will come with your own finished product. All this to say that surgery is very interesting, because I think, especially cardiac surgery, there's a lot of science, but there's also a lot of art into it. And I think many cardiac surgeons, you would probably agree, Mahesh, have this kind of dual personality, if you will, and this dual background, either sports or art or something else that made them perhaps more likely to be compelled by the field of heart surgery. And I think you'll find that quite often. Yeah. In my own life, I was a bit of an artist before, and I felt that some areas of medicine were a bit too dry, but cardiac surgery, I felt, was marrying really a lot of elements which are very left brain and right brain, if you will, right? There's a huge emotional component to it, right? It's dramatic, right? Yeah. It's very thrilling in some way, right? To be able to fix a problem. And the beauty with cardiac surgery is that, as I often tell my patients, well, we're going to have to do 2 valves and 4 bypasses, and your heart is weak and this and that. It's a big operation. But the beauty is that 95% of the time with heart disease, we're able to fix it, as opposed to some cancers or some neurological diseases where the odds of a hopeful solution are not as high, right? So I think for all these reasons, cardiac surgery is a great, great career. It's changing, and perhaps we'll talk a little bit more about that, but it's a great field.
Yeah, I think your analogy of the sculptor is a fantastic one. I've never heard that used before, because you're right. The apprentice learns, and then the apprentice goes on to do new things, which is what happens. Yeah. There is perhaps, the added element in cardiac surgery of the intellectual or the academic side of things, which may not be so prevalent on the sculptor analogy, but it combines both. And I think you do that beautifully. I mean, to an extent which is to be admired. Now, you talk about the duality, and of course, your own interest in the arts. Correct me if I'm wrong, but you're a pianist.
That's right. Yeah.
Yes. Yeah. Yes. So you had Did you play professionally at some point? Or?
I had a little bit of a mini career, if you will. I played a few times in Europe and did some competitions, which went well, both nationally and internationally. So, yeah, at some point I was kind of debating what I'd be doing. And, the fun part is that whatever you do, arts or sports, on the side of one's main career, can be continued, right? And so, for instance, we have a beautiful project next year of doing another fundraiser through music, and we've been able to raise, in the six figures for some hospitals, and we'll often, on a regular basis, do like some event where you say we want to start a new wing for a hospital or a robot or something like that. So it's been fun to be able to continue doing that.
Yeah. No, I think that's great. I think the other thing about being a musician and a professional musician, as you were at one point almost, is that there's an ethos of practice and a willingness to practice, not just a willingness, but enjoying practice in the pursuit of trying to achieve that elusive goal of perfection. I mean, as Rubinstein famously said, when I play, I only hear my mistakes, And I'm sure that's the case with you. Everybody else, the novices, just think it sounds wonderful, but and I'm sure this is the case with you, you only see or hear your mistakes. And so I think that ethos translates very well to cardiac surgery, but not everybody has it. Not everybody has reached your level of musicianship or in the case of some of our colleagues here, sportsmanship. But they want to do what you do. So what advice would you give to people?
It's interesting, you say that, because one commonality with the arts media and of achieving high-level performance, whatever you do, whether I'm a very poor skier, but if you're a downhill skier or you do a super G or something like that, is sometimes we'll finish an operation, Mahesh, and you the same, and you'll do a beautiful operation and with one of your trainees, and the trainee will tell you, "Oh, Dr. Ramchandani, this was a fantastic minimal invasive AVR. Like it was just perfect, such a beautiful operation." And I always feel like responding, and I know you think the same as well. Yeah, it was, but there are 10 things that I think we could have done a little bit better.
Yeah.
A bit more efficiently, right?
Yeah.
And we'll talk about that tomorrow at your meeting. But I think, first, we obviously have a gradation of what's important when we do heart surgery. And we want to provide this latest minimal invasive technology, which is in large part what your meeting is about. And you've led the field and you've led the educational aspect of being able to transmit that to young faculty and next generations. But our first and primary purpose is really to not harm, and it's safety, right? And it's to deal with the problem and not hurt the patient. So safety is always first. And I say it's a little bit like aviation, right? Surgery can be a bit like aviation. The first thing is you want the plane to not crash, right? The second thing is efficacy. You want the plane, if you're taking a flight from Houston to London, you're hoping to land in London. But guess what? If there's a problem over the Atlantic and you land in Reykjavik, it's not the end of the world, right? At least...
Well, that happened recently when Heathrow Airport... No. But Heathrow was shut down for 2 days recently.
Yeah.
They diverted flights.
So that's the efficacy, right? And the third aspect is comfort, right? And that's where the minimal invasive incision comes into play. So it's the business class upgrade versus, staying in economy class. And we all wish for the business class upgrade and that we're going to be looking in getting it. But frankly, if the plane crashes, it becomes very irrelevant, right? Yeah. So your comfort. So I think we need to use the same approach when we do innovative, less invasive operations. Yeah. But first, it's always about do no harm and keep the patient safe. Second, try to fix their problem. And third, if you can do it less invasively, well, that's great, right? But it's definitely a third priority behind the other two.
I'm so glad to hear you say that, because I think too many young people going into the field view that as the first priority, meaning no matter what they're going to do it that way, and patient safety does suffer. So sending them that message is, I think, so important. so important. And we certainly strive to do that here in the educational program that we have in the mixed fellowship program. Now, apart from your expertise in the field of cardiac surgery, I know you have a particular interest in coronary surgery, but you're very broad when you do everything well. You have somehow managed to combine that with an extremely productive academic career. So you're a very busy cardiac surgeon, and I know that. I mean, you're yet somehow your academic output, and more importantly, the mentorship that you have provided, is really an example that I look up to, and I know that many, many other people look up to. How do you do it?
Well, no, you're very kind. Thank you for that. But I think, if we get back to the coronary field, I think surgeons have a great role to play. And I'll say two things. I've always been amazed by the level of invasion that was needed to provide new arteries around the heart, essentially. And even as a resident, I thought there's got to be a less invasive way to be able to perform that. And you and I were part of the initial thrust towards making multivessel bypass surgery less invasive through thoracotomy, which basically had not been achieved until we and a few others were able to get into that field. There was midcap, there was single vessel to the anterior wall of the heart. But really, in terms of multivessel and now multi-arterial revascularization, there was really nothing. And the second aspect that was always important to me, perhaps as a driver, is that I feel that surgeons, we have this expression that surgeons are responsible for the skin and all of its contents, right?
Yes.
So that expression, it's a bit of a euphemism, right?
No,
but
it's so well
means basically that anything that happens to the patient ends up being your problem. And your role in decision-making, in sharing with the patient what is best for them, you need to understand everything. And I've always said to our trainees that you need to know the indications for valve replacement, valve repair, or aortic surgery, or coronary bypass surgery better than anybody else, better than a cardiologist. And it's like, why is that? Your cardiologist, because you are the one causing the invasion, right? You need to have complete justification and understanding as to why you will inflict that temporary invasion in order to make the patient better and have a better outcome. So it's very important to me that surgeons are involved in developing the science and not be mere technicians, because that way only then can they optimize what they do, back to the invasiveness aspect, and understand when their therapy is best and most appropriate.
Yeah. Now, in the field of coronary surgery, where you truly are a leader, there is a sense that the primary arterial graft, which is the left internal thoracic artery, to the LAD, which is an arterial graft to the main blood vessel on the front of the heart, for those who are not in the field, is really going to be difficult to improve upon. Do you think that statement will hold true in 10 or 15 or even 20 years from now?
I think it will hold true. Yeah, I think there will obviously one big aspect of the lethal LAD, as you know, and as many who are listening to this podcast know, is that it's biologically beneficial, if you will. It probably makes the artery upon which it's grafted healthier over time, right? So it eludes these nitric oxide derivatives, which basically refashion and improve the function of the lining of the artery, what we call the endothelial function. So that's a wonderful thing, especially in patients who truly need it because they have vasomotor dysfunction, because they have endothelial dysfunction, high oxidative stress, etc. All these things, for instance, that one would find in metabolic syndrome, diabetes, etc. So, even better, I would say, really my prototype coronary bypass surgery of the future, if you ask me, is to maximize the use of the internal thoracic arteries and use both of them and apply them and graft the left heart circulation with them and do this in a non-invasive way. And I think that's that's a great operation. I would argue that, if we were to share what do we think is the surgery of the future for 2040, it might be some of that, right? It might be a way that using those arteries that are there, that are available, that we know are the very best conduits, both of them, put them on the left heart in a non-invasive way, non-sternotomy way, without cardiopulmonary bypass, without aortic manipulations, without using vein grafts, without using cardiac anoxia or cross-clamping or cardioplegia. I think all these positive assets, we were discussing this morning the concept that minimal invasive surgery has to be as complete as the sternotomy surgery. Tomorrow, during the talk that you kindly invited me to give, I will even argue that in a way it can be better. Should we not aim to make it better? Less invasive and also with less manipulations and less potential for concerns, right? So I think in coronary surgery, paradoxically, we have that. We don't need to stop the heart. We don't need to do femoral cannulation. We don't need to put anything on the aorta, even clamp it. And we can, I think, capitalize on that advantage.
Yeah. No, I think that's great advice. One thing that I've wondered about, and I still struggle with, is the advice to give young early career surgeons, perhaps mid-career surgeons, on how to safely adopt minimally invasive or less invasive techniques in their practice of cardiac surgery. Because unlike new knowledge, which you can acquire by reading journals and books and going to meetings, these are new techniques which can be acquired, but need to be done so in a different way. And it's more of an incremental progress. And the big fear, of course, is that you don't want to compromise patient safety. You don't want the plane to crash. So how is somebody who's 5 years into training, who didn't receive any of this during his primary training, as is still the case in most programs, but who sees this as a way of the future, at least the medium to his career lifespan, 20 years, 30 years, whatever it may be, his or hers. How are they to adopt it safely? What general advice would you give?
No, it's a great question. It's the $2 million question, right? This is what your meeting is about, and this is what the many platforms that we participate in and believe in are about. We could have a very long answer, but I think the key point first is really safety and understanding that this new venture for any given team led by a surgeon will have to prioritize safety above everything else. The way as to how these operations can be done safely and with efficacy, I think it also involves mentorship and definitely support from the team as well, right? And there are so many things in a minimal invasive cardiac surgery operation that can go not optimally and lead to it not working, that it should be understood initially that conversions will happen. And you, Mahesh, and now me, and many others say that conversion, for instance, is not a complication. If you don't convert and you have a complication, well, guess what? That is a complication. But if you convert and you don't have a complication, should not be seen as a complication. It should be seen as part of expanding your program, expanding the indications, even teaching. I mean, sometimes I find it rather difficult to teach multi-vessel minimal invasive bypass surgery to residents and fellows. And sometimes I'll come in and there may be, one aspect of the operation which mandates that we have to convert and which the fellow did. But that's okay. If we don't have a complication, this is something that is part, the gold standard is still a sternotomy. So these patients are receiving the gold standard surgery. I realize it does not fully answer your question, but I think putting safety first, understanding that conversion is not a failure, and really capitalizing on the role of mentorship. I would also add, maybe as a fourth component, making whatever surgery that you're planning to make less invasive, incrementally less invasive in your own practice before you actually make the big shift to a non-sternotomy approach. Yes. So there are ways, for instance, to do this with valve surgery. There are ways to do this with coronary surgery. Yeah. Obviously, for coronary surgery, I always say be an off-pump master before. You come in and even contemplate doing a LITA LED via small thoracotomy. To me, that is the obligatory first step. If you do all your cases on pump and put ice on the heart to do grafts, it's not going to work, right? Yeah. So there are things even that the surgeon, with her or his practice, with her team or his team, can implement. And it's not just about the technical ability; it's really about the team mindset. And you, of all people, have spoken about this. It's a team sport, and to move into less invasive ways to do surgery requires team engagement. And the surgeon is really it's difficult at first, right? Everyone looks at you. How is this case going to go? How many hours is it going to take? Are we going to convert? Is the patient, first and foremost, going to be okay? And you're a little bit like on a crab fishing boat in 25-foot seas in the Gulf of Alaska, right? And you're the captain, right? And you need your team. On your own, you absolutely can't do anything. But there's a little bit of that component to it. So I think there's even an element of surgical leadership associated with it.
So well put. So well put. I think the reference to safety, I think, is the single most important piece of advice one can give. And I think when you reference conversions, I think you're talking about early conversions, which is what I espouse when you have doubt, because most of the literature on outcomes following conversions reflect late conversions, meaning you don't want to wait the patient. You don't want to wait for the patient to get into trouble before you convert. You need to anticipate that there may be a possibility of the patient getting into trouble and then convert so that everybody remains comfortable. I think that's an excellent point that you made.
Yeah, I'll even add, Mahesh, I believe in conversions. I think a program, if you have 0% conversion rate, I think there's something that you're not doing. You're either one or two things, and I teach this to my fellows. And I say you're either pushing too much, too often on a given patient, where perhaps you should be at some point, for failure to progress with the case, maybe at some point you should just call it, it's enough, especially in minimal invasive coronary surgery, which in my opinion is more difficult than minimal invasive coronary valve surgery. Because you need many, many exposures, right? It's not just a single exposure.
I agree completely with you, yes.
Right. So that's one aspect. And if you never convert, it also means that perhaps you don't push the envelope enough. You don't offer it to a sufficient fraction of patients. Again, this applies mostly to minimal invasive multivessel coronary surgery, but it's easy to just wait for the right candidate, right? And I'll tell you, on Tuesday, we had a referral. We came from 7 hours away. And this lady who absolutely did not want to have a sternotomy, and she had multivessel disease. And we ended up doing, LITA on a high BMI lady on the circumflex circulation and on the LED. And she's doing really, really well. And she kind of twisted my arm. She said, ma'am, I'm not sure I can do this. I've done high BMI males, but high BMI females and doing everything multi-arterial and off-pump through a small incision, I was foraying a little bit. But I did reassure her, I said, if I'm not progressing or we're not making sure that you remain safe and the surgery is effective, we will convert. And we ended up being able to maneuver through the surgery, and she had an excellent result. So knock on wood. It's still early result, knock on wood. But sometimes, taking that risk, it would have been very easy. And I felt I was compelled personally to say, no, we're not doing this. We're doing a multi-arterial sternotomy CABG off-pump, right? And we did it, and we learned something. And our patients are very happy. And I think these are sometimes crossing in the roads that one will have in establishing their minimal invasive practice, right? And it could have gone not so well, and maybe we would have converted and we would have tried again, right? And as long as you stay safe. And I would also argue, if you have a conversion, obviously be a bit more selective afterwards. You don't want to be in a team situation where you have 3 conversions in a row. That's not so good for morale. Again, it's back to that being the captain of a crab ship in the Gulf of Alaska, right? You have to understand team dynamics. And I know, Mahesh, you understand this very, very well. And most surgeons who've been able to establish very good programs have really considered those kind of right brain considerations, right? And not only with your patient and their family, but also with your team who provides care for them.
Yes. No, that's so well put. And I think what you said in this vignette that you provided about this lady who had come 7 hours to see you, you sort of almost glossed over it, but I didn't miss it. And it's about setting expectations with the patient and setting expectations with the team. And you more or less said this, but essentially what you were saying is you let everybody know that whatever happens, you will not compromise patient safety. So the patient knows that and the team knows that. And I think that just makes everybody more relaxed. And of course, when you're relaxed, you do good work, right? Because you're not tense. And tension comes from the mind, right? It's true, Marc.
That's true.
And if your mind is relaxed, as you know, I like to listen to music. Some people like silence. Whatever you like, whatever relaxes you. But setting the expectations correctly is so important. I'm so happy that you've come, Marc, because every year I know that the fellows and the other attendees look forward to the opportunity to not just listen to you speak, but to come and buttonhole you afterwards and ask you all these questions to which I know you provide, great answers because you've lived the experience. And, that's a wonderful thing. Before we close out, let me ask you something. When you're not working, what do you do?
Well, I enjoy the countryside, I must say. Yeah, that's something, a little bit of a just mindless work. Like we have a modest home on the ocean in eastern Quebec. Love to go there, and whenever we have a few days off, and it's a bit of a 4-season thing. In the winter, there's we always go on a snowmobile trip, if you will. The summer, we have a little boat there that. We can go out every day because the elements are fairly fierce, but it's something that I enjoy a lot. Spending time as a family and obviously, being in contact with one's environment. And I think that wherever you practice, that changes, right? There's a beautiful environment here in Texas, and you have a availability if you love the water in Galveston, or if you love more like a bayou-like type of panoramas. There's so many things to do, and I think it's wonderful to take time, I think, to resource oneself in contact with nature, right? And to me, that's my probably favorite activity, and even better if spent with family.
Yeah. Well, that's wonderful. I mean, I've known you for a long time, and one of the things that I've always noticed about you is that you've got terrific fashion sense. So somebody with good fashion sense who loves the country, I'd say you're a country gentleman. Thank you so much.
Well, thanks for having me. You're very kind.
Very kind. Thank you so much.